kindly request everyone to be seated. We are about to start our function. A healthy mind dwells in a healthy body. The best doctor gave the patient the best environment for a healthy tomorrow. A very good evening to the August gathering. It is an honor for me to stand before these invited guests and our Indian Doctors Forum members for this wonderful program. Myself, Dr. Jibin John Thomas, I am the Joint Treasurer for Indian Doctors Forum. Pleased to welcome you all to this continued medical education. And for the same, we have learned resource persons from Fortis Hospital, New Delhi, India, Dr. Rahul Bhargava, Director, Clinical Hematology and Bone Marrow Transplant, and Dr. Vikas Dua, Additional Director and HOD, Pediatric Hematology, Oncology, and Bone Marrow Transplant. Indian Doctors Forum Kuwait is a registered body with the Indian Embassy and also affiliated to the Kuwait Medical Association. It is one of the largest Indian organizations in Kuwait. We have more than 650 registered Indian doctors comprising of more than 2,500 family members. One of our main objectives is community-oriented services like organizing and conducting medical camps, seminars, CMEs, school health programs, and exhibitions for general public. Let me take this opportunity to welcome our distinguished dignitaries to the stage, our Honorable Ambassador of India to Kuwait, His Excellency Dr. Adarsh Swaiga. So please come to the stage. Our Kuwait Medical Association President, Dr. Ibrahim Al-Tawala, Dr. Salam Al-Shamari, Head of Department Bone Marrow Transplant, Kuwait Cancer Control Center, and President, Indian Doctors Forum, Dr. Divagara Chaluvaiya. CME is one of the key programs of Indian Doctors Forum, which is done very often and essential for all our practicing doctors to update with the latest developments, new technologies in medicine, to incorporate modern knowledge, to learn newer advanced treatment protocols and research outcomes in their respective fields. So this program is very important and beneficial for all of us. Let's use this opportunity to exploit the expertise of our resource persons. To start off today's program, let me call upon our dear President of Indian Doctors Forum, Dr. Divagara Chaluvaiya, for the welcome address.
Thank you, Dr. Jabin. Good evening to one and all. Salam alaikum and namaskar. Respected His Excellency Dr. Adarsh Swaiga, Ambassador of India to Kuwait. Respected President of Kuwait Medical Association, Dr. Ibrahim Al-Tawla. Respected Dr. Salam Al-Shimari, Head of the Department of Bone Marrow Transplant Unit, Kuwait Cancer Center. Our esteemed bone marrow transplant expert from Fortis Hospital, India, Dr. Rahul Bhargava and Dr. Vikas Dua. Esteemed members of Indian Doctors Forum, my dear colleagues, distinguished guests. As a president of Indian Doctor Forum, I extend a warm welcome to each and every one of you. As we gather here today for the continuing medical education session, it's a platform where knowledge evolves and our expertise deepens. The Indian Doctor Forum is privileged to be associated with today's CME on bone marrow transplant. As our colleague, Dr. Jibin told, Indian Doctors Forum is one of the leading Indian associations in Kuwait, registered in Indian Embassy and affiliated to Kuwait Medical Association. Indian Doctor Forum started in the year 2004. Recognizing the good work done by Indian Doctors Forum, the Indian government in the year 2013 bestowed with a prestigious award, Bharatiya Pravasi Samman Award, by the President of India. As a flagship event, the Doctors Forum conducts lot of free medical camps. This year alone, already, we have conducted more than 10 mega camps and 3 more camps along with the Indian Embassy. Indian Embassy is organizing a consular camps in remote areas of Kuwait. Along with that, we are conducting the medical camps too. Alongside, the Doctors Forum organizing many health awareness talks for the general public and school students. One of the event in the March 31st of this year, we conducted the awareness program on anti-vaping. The vaping is become very rampant in the school children. So we did an anti-vaping session in all the Indian community schools together on the same day, same time, and the same presentation. That was well received by the students, teachers, and this session was educating through the Zoom for the parents of the kids also at a time. So that we did that because the impact will be more if you do at a time. Dear friends, today we are privileged to have distinguished experts in the field of bone marrow transplant with us to share their insights and achievements and advancements. As we embark on this education journey, let us embrace the opportunity to enhance our understanding of the intricacies surrounding the bone marrow transplantation. Let us engage, learn, and foster the collaborative spirit that will undoubtedly contribute to the progress of our collective knowledge. Thank you all for your commitment to continuous learning and pursuit of excellence in patient care. May this session be a source of inspiration and innovation to all of us. I conclude my few words once again welcoming all of you for today's CME and thank you. Long live Indo-Kuwait relationship. Thank you.
Thank you, sir, for the warm welcome. It is with great pleasure and immense honor that we welcome a distinguished individual among us today. Our special guest, Dr. Salem Al-Shameri, consultant hematologist, head bone marrow transplant unit, KCC, and associate professor in Faculty of Medicine. We welcome you, sir, to address the gathering.
Thank you for these kind words, Mr. Ambassador. Pleasure to meet you, and Dr. Ibrahim Tual, pleasure to have you here. Ladies and gentlemen, the Indian Forum, I try to attend the Indian Forum regularly, especially Ramadan. That's very, very kind and very nice. So honestly, we are no stranger to the Indian Forum and the Indian physician. And I was taught by Indian physician. I trained with Indian physician. I actually visited AIMS when I was a medical student, where I did elective for 1 month. And so I learned a lot of things. One of them is, medicine is a discipline. It's not really just a profession. It's really a discipline. So you start, I went there as a locum. So we thought, as medical students, we'll have some fun and train. But to my surprise, we were 5 of us. We were called to join at 7 a.m. To pick up cases. And then we started the round with the professor 9 a.m. and 6 hours continuous standing, no coffee breaks, nothing. So it was a lot of learning, and I always think, although at the time we were immature students, but you learn things as you go on because one thing I noted in the rounds, students were actually their residents. They were giving history without reading a paper. They were very diligent in the history. And when I asked why they are doing this, he said, if you don't have a diagnosis by the history alone, you are lost. You cannot reach a diagnosis. And that actually taught me a lot of lessons in human and their skills much better than machines. And that actually, I always say that saved my life many times. I'm patient because MRI can give you wrong reading, PET scan can give you have to use your skills to. The other thing is we were asked to write cases. So cases, whenever we see a case, we have to write the history and in a meticulous way and physical, and you have a differential diagnosis. So I kept a lot of notes from 1986, which I still have. It was, we called it 30 interesting cases from India. And I still have the booklet, and we typed it with a typed machine. So it wasn't like, and I still have it. But that actually taught me a skill that I used it now. In the last 3 years with the corona, I made the same thing when I write notes or write my grants, research grants. I kept all the notes for the last 10 years, and I made my book when I updated it. Hopefully it will be published in the coming few months. And these two principles I really learned it when I was in Ames. I mean, why people spend so much time in history. I remember very well, maybe to your surprise, Dr. Ramesh, there was no X-rays, no CBC, nothing. We just actually have to pick up the diagnosis from seeing these patients. So these two skills really helped me a lot in my career. And many of our colleagues now also help us in advancement of medical sciences in Kuwait, especially hematology, for example. At least I had the honor to work with Dr. Ramesh for so many years. So pleased to be here. Thanks for the invitation. And I think the topics selected are very nice. I mean, we've been doing transplant the last 20 years and transplant therapy for 50 years, but in the last maybe 50 years of plus minus, we are talking about alternative source of stem cell because many patients do not have donors, and with the hablos and other alternative sources became very important. Also, they talk about using immunosuppressive, basically transplant in immune disorders like sclerosis and patients with multiple sclerosis. Are these becoming really something for the future and hope for so many patients? So thanks for the invitation and pleased to be part of this activity.
Thank you, sir, for those good and motivational words. We feel honored to have with us today His Excellency, the Indian Ambassador to Kuwait, Dr. Adar Swega. Sir, you hardly need any introduction. You represent India in Kuwait. I feel privileged to invite you to give the inaugural address.
Good evening, namaskar. First of all, let me congratulate IDF for organizing this event and for calling very distinguished specialist doctors from Fortis, India. As Dr. Divakar mentioned earlier, many of us, in fact, many other members of IDF, and as Mr. Shamari said, he is not a stranger to IDF, but I would also kind of buttress the point that IDF, yes, it is an organization composed of Indian doctors, but they have truly been superlative in the performance. In the last 1 year, I have come across a lot of IDF events, and the kind of zeal and enthusiasm they do events. Particularly, we did some consular camps. He mentioned about it. They went for free medical camps in scorching heat. It was almost 45, 50 in May. We did our last camp, and I was very, very heartened to see that they were giving medical advice for free to a lot of marginal workers, and that benefited them a lot. So apart from that, they have been organizing blood donation camps in cooperation with the embassy and otherwise as well. So I think this event also is in same vein, and I congratulate them once again. Now, coming to this conference, it is always good to organize such events because science is growing very fast. It's not that once a doctor, always a doctor. People used to believe that, but science is progressing very fast, and therefore the doctors also need to keep abreast of what is happening in the particular domain. And therefore, exchange of experiences, exchange of knowledge, exchange of practices is so very important. Dr. Shamari was mentioning about AIMS, his experience of AIMS. It's something that inspires so much of confidence in every Indian. Wherever they can have advice, they will like to get an advice from AIMS because I think they have built a reputation of that, and therefore it's the best medical institution in the country, and we are so proud of it. Now, coming to, yes, we have a lot of Indian doctors in Kuwait, there are a lot of nurses in Kuwait, but there is also a lot of scope for medical cooperation, not only in terms of doctors and nurses, but in other fields. For example, Kuwaitis are traveling around the world to many Western countries for medical treatment. I think I would like to take this platform to tell that you can avail of world-class treatments in world-class hospitals in India, and Fortis is one of them. So that's another thing which we as a government are discussing with the Ministry of Health of Kuwait of the possibilities in this regard. Secondly, again, we hear about so much about India being the pharmacy of the world. Now, while that's very much true, most of the Indian, 40%, I don't know the exact figures, but a bulk of the Indian drugs are US FDA and Europe approved, but still you find very less in Kuwait. So I think that's another area where we are working very closely with the Ministry of Health, and we hope to see more and more of Indian medicines in Kuwait. So and similarly, in the case of medical devices today, under the Make in India program of the Government of India, a lot of very high quality, high standard medical devices are being manufactured in India, and that again opens up another avenues of cooperation between India and Kuwait. So I would say that while we have very, very good vibes of medical cooperation with the presence of such a strong doctor and nurses community from India, I think there are other important areas in this field that can strengthen the bonds between our two countries. So these were essentially the points I wanted to highlight. I am sure this discussions by both the doctors from the Fortis Hospital will add value to the hematology practice in Kuwait, and I wish the conference full success. Thank you.
Thank you, His Excellency. And now we would like to felicitate our guests for the day. I would like to call upon the President, Indian Doctors Forum, Dr. Divagara Chaluvaiya, to present the memento to His Excellency, Dr. Adarsh Swaika. Thank you, sir. Next, I would like to call upon His Excellency, Indian Ambassador to Kuwait, Dr. Adarsh Swaika, to present the mementos to our guest of honor, Kuwait Medical Association President, Dr. Ibrahim Al-Tawala. I would also request His Excellency to present the memento to our special guest of the day, Dr. Salim Al-Shamari, Head of Department BMT, Kuwait Cancer Control Center. I would request Dr. Ramesh Pandita, Consultant Hematologist, Kuwait Cancer Control Center, to come onto the stage and present the memento to Dr. Rahul Bhargava, Principal Director Hematology, Oncology and Bone Marrow Transplant, Fortis Hospital, New Delhi. Thank you, Dr. Ramesh.
Thank you.
I would request Dr. Samir, Vice President, Indian Doctors Forum, to come onto the stage to present the memento to Dr. Vikas Dua, Director and HOD Pediatric Hematology, Oncology and Bone Marrow Transplant, Fortis Hospital, New Delhi. Thank you, Dr. Samir. Thank you all distinguished dignitaries for gracing us with your presence on this special occasion. As we conclude the introductory session, I would like to extend a warm invitation to our esteemed dignitaries on the stage to join us down with the audience. Thank you. As we approach to the commencement of our CME, we would like to ensure that all participants have had the opportunity to complete their registration by giving your contact details. If you have not registered, we kindly request you to do so at the registration desk. The first topic of the day will be on haploidentical bone marrow transplant in pediatric benign hematological disorders, which will be given by Dr. Vikas Dua. The moderator for this talk will be Dr. Salem El-Shameri. Let me take a few minutes to introduce more for our moderator of the day. Dr. Salem El-Shameri. He graduated from Kuwait University, followed by his FRCPC Hemato-Oncology from Western Ontario University, Canada, and fellowship in hematopoietic stem cell transplantation from Fred Hutchison Cancer Research Center, USA. He was instrumental in establishment of stem cell transplant in Kuwait. He was the chairman of Medical Oncology, Malignant Hematology, Ministry of Health, Kuwait. He also served as the chair, Faculty of Oncology, KIMS. At present, he is the consultant hematologist, head bone marrow transplant unit, Kuwait Cancer Control Center, and associate professor in Faculty of Medicine, Kuwait University. He has more than 50 publications under his name, as well as many research and review articles. It is our great honor to have you here, sir. We welcome you, sir, to moderate this session, please. Before the CME starts, I would like to invite Dr. Rahul Bhargava, Director, Clinical Hematology and Oncology, BMT Fortis Hospital, to briefly talk to us regarding their BMT program, followed by the first speaker, Dr. Vikas Dua.
Very good evening, namaskar and salam alaikum. It's an honor to talk about the place where we work in. Just to give you a glimpses, we are a country of 1.4 billion. Okay, that's a huge, from 4 million to 1.4 billion. And we represent Fortis Healthcare, which owns almost 3,000 plus beds across the country, with 28 hospitals spread across the geography of India, which is like vast, right from Srinagar to Kanyakumari, as we understand. It's an ocean in itself and a continent in itself as we speak of India. And it's not just that, we represent one of the state-of-the-art bone marrow transplant centers across Fortis, which we have got 26-bedded bone marrow transplant unit, and which serves not only Indian citizens, but across 45 countries across the world coming for bone marrow transplants, like right from Mongolia to West Indies to Africa to Middle East and of course the CIS and Southeast Asia. And now in past couple of years, people all across from Europe has started coming for multiple sclerosis bone marrow transplants from Europe and US for variety of reasons, because of the trust the Indian healthcare has earned over past so many years. And it's just not only the trust, it's the cutting edge technology. Just to give you the glimpses, like 70% of myeloma docs in US are Indians at this present moment of time. If you talk about hematologists across US, 40% belongs to Indian community. And if you talk about the current presidential candidate, Venkat Swamy, he's a first generation Indian. So India is spreading its wings very fast, not only in technology, but soft skills and healthcare. And the infections has become the history and is talk of the past. When all of us 20 years back, 15 years back, left country, probably we were still considered as the snake charmers. From there to the digital technology, to the people who have reached to the Mars, and the only country in the world to land the satellite on the West Pole, North Pole of Moon. That's the strength of India at this present moment of time. So with this, I thoroughly welcome and obliged and really indebted to Kuwait Medical Authorities and Association along with IDF to give us an opportunity to showcase the strength of Indian healthcare, which is of saving lives. And the promise while we leave this place after 1 hour, it will be that across nations, across seas, across mountains, our endeavor will always be in a true Indian spirit to help people across the world, irrespective of caste, creed, nationality, or religion. That's the motto we always stand for, and that's what we serve as Fortis, one of the places we work for. Thank you, everybody, and happy listening to this.
I would kindly request Dr. Salim Al-Shameri to introduce our speaker for the first topic, Dr. Vikas Dua.
It's a pleasure to introduce Dr. Vikas. It's actually a very important topic, and the transplant has been established over 50 years ago. We have really, many patients were cured benign and malignant with auto transplant. The issue, as we know it, became in finding a proper source for source donation, stem cell donation, especially for patients with malignancies, but more particularly important in children where they have many benign conditions. Although we call them benign, they're really not benign. They have shortened survival, they have very poor quality of life. To mention a few, SCIDs or sickle cell anemia, homozygous sickle cell anemia, thalassemia major, and maybe until recently, at least for thalassemia, with the advances in chelation therapy, most patients will probably die early in their 40s. Sickle cell anemia, the same story. Now we know things has changed for them by, and the same thing applies for acute leukemia where there is no source. And in countries with limited resources, finding unrelated match transplant was not an easy. You have to establish a registry, you have to establish a cord blood bank, but that doesn't work all the time. So the alternative was Habluz, and maybe in the last 10 years or so, Habluz has saved many lives, and some results are really almost as. So we have the best person to talk about it, at least talk about benign, although again I put it between the double quotes, benign hematological disorders, and Professor Vikas can tell us, he has a lot of experience in that. He has written about this topic and published many, and he's done, I believe, over 600 cases related to pediatric disorders. Professor Vikas.
Thank you very much, sir, for the kind introduction. And at the outside, I would like to thank the Indian Association for inviting me and having me here. And friends, I can see that there are quite a number of hematologists and doctors from other specialties are here. So I've divided my talk into two parts. The first part, I'll be talking in general about transplants, what bone marrow transplant is, for what conditions we do a transplant, very briefly, who can be a donor, what if you don't have a full match donor in the family, and what Professor was talking about, if you don't have a full match donor in the family, what other alternatives are there, and what best we can do for these kids who have been suffering from disorders like thalassemia, sickle cell, because India being a thalassemia capital of the world, we see quite a number of thalassemics in our country. And as India has become a place for medical tourism, we see a lot of people, a lot of patients coming from abroad, coming to us for transplants. So we have done transplants from 76 different countries, and like thalassemia, Nigeria is the sickle cell capital of the world. And in our center, we have done close to 100 transplants for sickle cell. So we'll be, in the later part of the talk, we'll be focusing on benign disorders like thalassemia, sickle cell, aplastic, and inherited bone marrow failure syndromes. So to start the presentation, I would like to discuss this case. So this boy came to us all the way from Basra almost 10 years back. In 2013, this boy was diagnosed with a problem called Fanconi's anemia, which our hematologists are very well familiar with. I inherited bone marrow failure syndrome, in which your red cells, white cells, and platelets are not being formed. And the only solution for Fanconi's anemia or any other inherited bone marrow failure syndrome is a bone marrow transplant. ATG, anti-thymocyte globulin, doesn't work for inherited bone marrow failure syndromes. Unfortunately, his elder brother also had Fanconi's. It's an autosomal recessive disorder. His elder brother also had Fanconi's anemia, died at the age of 15 because of IC bleed. So family wanted to have a cure, wanted a permanent solution, came to us from Basra, and we were also very new in haplotransplants at that time. I came back from Singapore after finishing my transplant fellowship, and then I spent some time in St. Jude's in Memphis, and then I came back to India, and I learned how to do a haplo, but doing that on my own was something new for me. So this family came to us, and we did the transplant, and we were in the news because that was the first successful transplant for Fanconi's anemia which was performed at that time. The boy is still alive, doing well, off transfusions, and is now, he was, I think, if I'm not wrong, he was around 10, 11 years old, and he's now 21. So that's the beauty of transplant. And if you don't have a full match, still a transplant can be done by getting an alternate donor, by getting an unrelated donor, how, that I'm going to tell you. Or if that is also not the case, then even the parents can become the donor. 50% of our genes comes from father and 50% of our genes comes from mother. So a patient is 50% matching with the father and 50% with the mother, unless and until you have a consanguinity. There are a lot of challenges when we think of doing a haplotransplant in terms of graft versus host disease, rejections, infections. But with that successful transplant which we did for this boy, now we have done more than 180 transplants, haplotransplants in our center. So we'll talk briefly about the indications for which we do transplants. What is the donor typing? What are the types of medicines or conditioning which we use? What are the harvesting techniques? The most important thing in a transplant is supportive care and GVHD prophylaxis. This is what we are going to discuss. Just very brief background to this topic for the non-hematologists who are sitting over here. So friends, the first successful transplant for adult patient of leukemia was performed in 1969 by somebody called Dr. Thomas. And thalassemia, which is a very big problem in our country, a hemoglobinopathy in which a patient requires monthly blood transfusions from the age of 6 months. The first successful transplant for thalassemia was performed by the same doctor, Dr. Thomas, in 1981. And the beauty of that transplant for that thalassemic boy, the boy who was transplanted at the age of 1 is still alive, transfusion independent, 42 years post-transplant. And for his work, Dr. Thomas got a Nobel Prize in 1990. So friends, we can collect the stem cells from the bone marrow. The donor goes to the operation theatre, and from the posterior superior iliac spine, you collect the stem cells. Nowadays, there's an easier way. Easier way means you can collect the stem cells from the blood. The donor gets some injections under the skin for 5 days, which would mobilize the stem cells from the bone marrow to the peripheral blood, and in the blood bank, without any sedation, you can collect the stem cells. We can debate what is the good about a bone marrow harvest and the goods about peripheral blood harvest, but peripheral blood is an easier technique, is an easier way, easier for the donor to donate. And third source is cord blood. When a newborn baby is born, from the placental side of the cord, you can collect the stem cells, and that can also be used as a stem cell source. In general, friends, there are 2 types of transplants. One is autologous and second one is allogenic. Auto simply means this: the patient himself is the donor. I'll talk about the indications later. The patient himself is the donor, and in allotransplant you require a donor. Just understand this. 2 types of transplant: auto, allo. Now, when we talk about allotransplant, who is the best donor? The best donor is a brother or sister. We do a test called HLA to see whether the siblings are matching on HLA or not. To give you an example, let's say I'm thinking of doing a transplant for a 2-year-old thalassemic. and has got a brother, elder brother, who is 80 years old, the first thing I'll do is I'll do a test called HLA to see whether they are genetically matching or not. There is a 25 to 30% chance that the sibling would be a complete match to the patient on HLA, which simply means, let's say 100 patients require a transplant and have got siblings, 25 to 30 you will have a full match. That's called a match sibling donor transplant. Easy ball game. It's a very easy ball game because the chances of complication is less. Less chances of complications, less chances of infections, better immune reconstitution, less chances of rejections, less chances of a problem called graft versus host disease. But if you don't have a full match donor, I'll come to the indications later. If you don't have a full match donor, then what? Then we search the donor from outside the family. There are national and international registries from where you may get a donor. In India, we have got a registry in the southern part, in Chennai, called Datri. Datri has got roughly 400 to 500,000 registered donors. That means if a transplant physician like me, who is thinking of doing a transplant, I again give you the same example. Let's say I have a 2-year-old thalassemia and has got one sibling who is 8-year-old. I do the HLA typing and they are not matching. Then what? The option of match sibling is not there. Should I defer transplant or should I search the donor from outside the family? So I will put that HLA report into a search, into Datri search. And in their database, if they find somebody whose HLA is matching with my patient, they will let us know in 48 hours, yes, we have a donor for your patient. It's not that 400,000 or 500,000 donors are sitting with Datri. They conduct camps in school, colleges, do their HLA, get the reports, put them in database, and then if a transplant physician like us put the HLA report into a Datri search, and if we have a donor from Datri's registry, then they can block. They can ask the donor, are you ready to donate? If the donor says yes, they do some battery of tests to see whether the donor is clean or not. They repeat the HLA called confirmatory typing to be 100% sure that the HLA of the patient and the donor is actually matching. That's called match unrelated donor transplant. The donor doesn't have to be physically present at the transplant center where the transplant has been done. We finalize the date with the donor, and then once a date has been finalized with the donor, with the family, with the doctor, the donor donates stem cells at X place, and the stem cells are being shipped to our center and we can do the transplant. Let's say Datri's donor is there in Calcutta. Then there is an authorized center where stem cells can be collected and stem cells will be shipped. So friends, that's called unrelated donor transplant. But let's see how much are the chances of finding unrelated donor. Somebody who is of Indian origin, Asian origin, there is a 41% chance. Whereas if somebody is a white, Caucasian, there is a 77% chance. Which means that not each and every patient will have a match sibling or an unrelated donor. I said 25 to 30% chance of finding a donor in the family, and roughly another 20-25% chance of finding a donor outside the family. But still there would be 50% patients for whom neither you have a full match donor in the family or outside the family. So should we now say to the family that as you don't have a full match donor in the family and outside the family, we will not do a transplant, or we do a transplant which is called haploidentical transplant? Haplo means half match. 50% of our genes comes from father and 50% of our genes comes from mother. So parents are usually 50% matching. So you can do, if you don't have a full match donor in the family or outside the family, then you can sit with the family, discuss the pros and cons of haploidentical transplants. What pros and cons that I'm going to tell you, because in a benign disorder that's very important. In a malignant disorder, the family doesn't have a choice. He has to go for a transplant. Like if a patient requires a transplant, let's say for a blood cancer, acute myeloid leukemia, a relapsed acute myeloid leukemia, we know the fact that relapsed AML cannot be treated with conventional chemotherapy. We give the patient chemotherapy, get him into remission, and we need to do a transplant. If you don't, for that patient, if there is no match in the family, outside the family, then he doesn't have a choice. He has to go for a haplotransplant. Whereas a patient who has got a problem like thalassemia, in which the patient can still live with monthly blood transfusions, it is very important for the transplant physician to counsel the family in detail the pros and cons of a haplotransplant before we proceed further. So that's in brief the types of transplant what we do. Coming to the indications, friends. So we divide the indications into two parts. One, malignant, and second is non-malignant. So I'll just tell you very briefly the indications when it comes to malignant indications: bad leukemias, relapsed ALL, relapsed AML, high-risk ALL, high-risk AML. Myelodysplastic syndromes are not very common in pediatric age group. It's a disease of growing age, but we do see MDS in pediatric age group. That's another indication for doing a transplant. Bad lymphomas, a relapsed lymphoma like Hodgkin's lymphoma, a relapsed non-Hodgkin's lymphoma, you need to do an autologous transplant. Then comes brain tumors, neuroblastoma. You must be wondering, what is hematopoietic stem cell transplant going to do in a patient of brain tumor medulloblastoma or in a patient of neuroblastoma? So the logic of doing a transplant for a patient of hematopoietic stem cell transplant or for a patient of medulloblastoma or a neuroblastoma is that you want to give heavy dose of chemotherapy. Let's say a patient of neuroblastoma, metastatic neuroblastoma is there, and you know that with conventional chemotherapy you will not be able to cure that patient, and you want to blast that patient with a heavy dose of chemotherapy. You collect his own stem cells. You blast the patient with heavy dose of chemotherapy, and you give his own stem cells back to rescue his marrow. So that's the logic of doing an autologous transplant in non-hematological conditions like brain tumors and neuroblastoma. Then the topic of discussion is benign disorders. For benign disorders, we do transplants for aplastic anemia. There are other options like giving ATG, cyclosporin. That's one option, but the better option is a transplant. Then quite a number of inherited bone marrow failure syndrome patients we see in our practice, like Fanconi's anemia, disc keratosis congenita. Our pediatric friends must have heard about these inherited bone marrow failure syndromes. Schwartzman-Diamond anemia, amagrocytic thrombocytopenia, Diamond-Blackfan anemia. The only cure is a transplant. Immunodeficiency, friends. So those of you who are into general pediatrics, you must be seeing patients to your clinic coming with failure to thrive, not thriving well, a thrush, otitis media, recurrent pneumonitis. Think of SCID. Think of immunodeficiency. Do a lymphocyte subsets. Do a immunoglobulin profile, because it's very important to refer these patients to a transplant center, because if you don't do that, they will stop coming to a clinic, probably would pass away. So it's very important to send patients who have got immunodeficiencies like severe combined immunodeficiencies early to a transplant center. Sickle, a very common problem in Africa. Nigeria is the sickle cell capital of the world. Quite a number of patients from Africa travel to India for sickle cell transplants. These patients are also suffering recurrent pain crisis, chest syndromes, history of stroke, priapism, sickle nephropathy. Practically any part of the body can get involved. We have done quite a number of transplants for sickle cell even from Oman, few from Bahrain. Sickle patients need transplant, and that too a allo transplant, because your own hematopoietic system is defective. Then thalassemia. I'm pretty sure all of you know about thalassemia. India being the thalassemia capital of the world, we transplanters in India, we do left and right transplants for thalassemia. From the age of 6 months, they get monthly blood transfusion, and sooner the better. It's always advisable to refer a patient who has got thalassemia early to a transplant center so that transplant can be done. Because if they reach a transplant center late, they might be iron overloaded, They might have complications like veno-occlusive disease of the liver. They may have cardiac issues, and because of the allo sensitization, because of the multiple transfusions, there would be more chances of rejection. Then last but not the least, any pediatric hematologist or transplant physician does transplants for metabolic disorders like Hurlers, Hunters, Gauchers, quite a number of lysosomal storage disorders. Now the indications of transplants have come up because leukocyte has that defective enzyme which the patient is lacking. So you give some chemotherapy, you ablate the patient's marrow, replace that with a healthy marrow which has got leukocyte, which will replace that defective enzymes. So these are, in general, friends, the indications of doing you call it bone marrow transplant, but the correct term, the newer term for last few years is hematopoietic stem cell transplant. So let's move further. So this is in general about transplant. This we have already discussed. No full match in the family, then unrelated transplant. Then definitely there is one more way of doing a transplant, which is cord blood transplant. We in India are not very comfortable, I would say, in doing cord blood transplants because of its own problems, delayed engraftment, naive cells, and sometimes you can have issues with the viability. So many centers in India are actually not doing cord blood transplants. We have learned how to do a transplant when we were doing transplant fellowships, but we are not practicing it anymore. So if a full match donor is there in the family, we go ahead with a full match transplant. Otherwise, we search a donor from outside the family depending upon what condition it is. If it's an urgent transplant like leukemia, rather than waiting to get a donor from outside the family, we counsel the family and quickly proceed for a haplotransplant. Now friends, coming to the topic of today's discussion, haplotransplant or alternate donor transplants for benign hematological disorders. So as there is a mismatch between the donor and the patient, there are more chances of complications. More chances of complications means more chances of complications like graft versus host disease. In a simpler way, if I have to tell you, donor cells going into patient's body and saying that it is not my body, attack. So they can attack the skin, gut, they can attack the liver. So you can have rash, you can have diarrhea, vomiting, you can have jaundice. That's called acute GVHD. And those patients who get acute GVHD have got more chances of having a chronic process, a chronic GVHD also. That's one problem which can happen in a mismatched transplant. Second, as the immune reconstitution would be delayed, there would be more chance of infection, more chances of fungal viral reactivations in a haplotransplant. And also the third problem, more chances of rejection. So there are two ways. Broadly, there are two ways of doing a haplotransplant. One is called T-cell repleted transplant and another is called T-cell depleted transplants. So T cells are the culprit cells, are the cells which cause GVHD. So one way is you deplete the T cells outside the body. That means, let's say, I give you an example. I have a patient who has got sickle cell, has come to me from Nigeria, 12-year-old, recurrent pain crisis, history of stroke, chest syndrome, and not doing well on hydroxyurea, referred for a transplant. Doesn't have a full match donor, doesn't have a half match, doesn't have a unrelated donor, and counseled for a haplotransplant. If I decide to do a T-cell depleted transplant, I will collect the stem cells from the donor, the way I do it for a match sibling transplant, giving GCSF injections under the skin, mobilizing the stem cells from the bone marrow to the peripheral blood, and before infusing with a special kit, with a special machine, we deplete the T cells and infuse the rest of the product. So when this understanding started, the first thing what people were doing, they were doing a positive selection, collecting the stem cells, taking out only the positives, only the CD34 positive cells, and infusing that. So what they noticed is that more chances of infections were there, more infections they were noticing, because they were depleting the T cells, they were also depleting the NK cells, dendritic cells, which are actually good, which is required to fight against the infection. So then they thought that rather than doing a positive selection, let's just deplete the T cells and give rest of the product. Rest of the product means CD34 cells, dendritic cells, memory cells, and NK cells. The chances of infections went down. Then as they learn more of immunology, they came to know that the T cells are of two types. T cells, which are alpha beta cells and gamma delta cells. T alpha beta cells are the culprit cells, are the cells which causes GVHD, and gamma delta cells are good cells, are the cells which help in engraftment, which fight against infection. So then people started removing only the T alpha beta cells, the bad cells. That's called T alpha beta depleted transplant, and they were infusing the reserve product. So just in brief, this is a T cell depleted transplant. There is another way. There is another way of doing a haplotransplant, and that's called T cell repleted transplant. That means you collect the stem cells, you infuse the stem cells, the whole product, and on the third and fourth day after the transplant, you give a medicine called cyclophosphamide. We all, those of you who are oncologists, are very much familiar with cyclophosphamide. So when you give cyclophosphamide, specifically on third and fourth day post-transplant, they attack the alloreactive T cells. Alloreactive T cells are being attacked of the donor are being attacked by cyclophosphamide, and the chances of GVHD goes down. But as this is an in vivo depletion, still there would be some which would be left, and still there would be a chance of GVHD. So in general, with a T cell repleted transplant, you will have, I would say, around 25 to 35% chance of GVHD. So it is the transplant physician who has to decide whether he wants to go with a T cell depleted, T alpha beta depleted transplant, or wants to go with a T cell repleted transplant. So I would say that nowadays in a country like ours, haplotransplants are on a rise and MUD is getting plateaued. I would say many centers in our country, if they don't have a full match donor, they move on to a haplotransplant because the understanding, the experience in haplo is increasing day by day. There are pros and cons of each and everything. In a haplotransplant, the pros are like almost everybody has a haplo donor. So everybody, any patient who has come to you for a transplant who doesn't have a full match in the family must be having at least a parent who is alive, must be having a sibling who is a half match. So every patient can undergo a transplant. Nowadays, with improved understanding, with better results, by using a PTCY technique, the outcomes are improving, and the donor is available immediately. You don't have to wait, because when you do an unrelated transplant, you may have to wait for 4 to 12 weeks. The haplo donor is immediately available, so you don't have to wait, and you don't need a registry. And the cost of T cell repleted transplant is almost similar. The immediate cost is almost similar to a match sibling donor transplant. But there are cons also. There are challenges, as there is a mismatch, more chance of rejections, more chance of GVHD, more chance of transplant mortality. When you do a T cell depleted transplant, that means you're depleting the T cells outside the family. There will be more slower immune recovery, more chance of infections. Whereas if you do a T cell repleted transplant, though the immune recovery would be faster, but more chance of GVHD. So there is a good and bad about each and every type of transplant. The PTCY technique is called John Hopkins technique because that's the place which pioneered the PTCY work, and it's almost similar like a match sibling donor transplant. Just you have to individualize each and every case. You have to decide what conditioning to be used, and then on the third and fourth day you have to give this drug called cyclophosphamide. Initial cost is almost same as a 100% match transplant. You just need a basic infrastructure. You don't need expensive medicines, expensive, I would say, kits to deplete the T cells. Whereas the German way of doing transplant, haplotransplant, T cell depletion, it's different from a 100% matched transplant. There is an additional cost of depleting the T cells. Roughly, you have to pay around $18,000 to $20,000 in India. Additional cost when you are thinking of doing a T cell depleted transplant. And we need advanced infrastructure. Then there need to be more experienced doctors who can do this T cell depleted transplant. So friends, in general, benign versus malignant, they look similar but are definitely different because mortality acceptance is poor in benign disorders. So if I give you an example, you have a patient who's got thalassemia, you're doing a haplotransplant, you need to do multiple counselings before you proceed for a transplant, because in case, God forbid, you have a TRM, you have mortality, at least the family has to understand that. Understanding of the family is very important, whereas in a malignant disorder, I would say still they would accept. There's a smart immune system in benign disorders. Like for thalassemia, when you're doing a transplant, the patient is multiply transfused. A 10-year-old getting a transplant for thalassemia, getting monthly blood transfusions from the age of 6 months, there are more chances of rejection. Multiply transfused, iron overloaded liver, more chances of complications, more chances of liver issues, more chances of liver failure, more chances of, I would say, veno-occlusive disease. But in general, I would say that the good thing is that the reported outcomes are better for a benign disorder transplant as compared to a transplant for a malignant disorder. Coming to thalassemia. So when you talk about a thalassemia patient who's been getting transfusion from the age of 6 months, so there are two ways. Either you continue them on monthly blood transfusions for the rest of their life, start iron chelators when there's an iron overload, or you give them a one-time solution in the form of a bone marrow transplant. Sooner the better. If you do a transplant early, let's say you do a transplant for a 1.5, 2-year-old boy, the outcomes in a center like ours is close to 95 to 98%. Whereas if you do a transplant for a 18-year-old thalassemia who's been iron overloaded, not properly chelated, not compliant in taking the iron chelators, the outcomes still hover around 70%. So when it comes to an unrelated donor transplant or a half-match transplant, it is important that you counsel the family properly and you have a thorough understanding, and you should have an experience of doing a transplant for these disorders. So this publication from Sodani et al. Came back in 2010 in Blood Journal, in which they shared their experience of doing a T-cell depleted transplant for thalassemia, and there were around 22 patients. To suppress their immune system, they gave hydroxyurea as a thiopurine, and they used a conditioning which was fludarabine, busulfan and cyclophosphamide thiotepa based. And out of 22, 2 patients expired and 6 rejected. So this was way back in 2010, 13 years back, still respectable outcomes. 14 out of these 22 showed full donor chimerism, and at 40 months post-transplant were doing well. Survival of 90% and thalassemia-free survival of 61%, I would say, was still acceptable in 2010 when many centers were not doing haplos for thalassemia. But there was an additional cost which is being involved in these types of transplants which we have already discussed, because this is a T-cell depleted transplant. So then this publication came from Thailand, from Suradesh group. They shared their experience of doing a haplotransplant with a PTCY based technique, and by giving 2 cycles of pre-transplant immunosuppression to suppress the immune system. Suradesh and group, they gave 2 cycles of fludarabine, dexamethasone at a gap of 21 to 28 days. Then with ATG, fludarabine, busulfan, PTCY based conditioning, they treated around 18 patients. 18 haplotransplants were done, 10 males, 8 females, median age was 16 years. 10 out of 18 were high-risk class 3. And along with Fludex, they continued these patients on hydroxyurea to suppress the erythropoiesis. Fantastic results. 16 out of 18 engrafted with full donor chimerism, just 2 rejected. EFS and OS of close to 95%. So when this publication came, people were very excited that we can do a transplant, a haplotransplant for thalassemia with PTCY based conditioning, and we can achieve a cure rates close to 95%, which is similar to what people achieve for a maximum transplant. So when their data matured, they had another publication of 31 patients, 15 were high risk, 7 class 1, 9 class 2, and this was published in 2016. A similar conditioning, fludarabine dexamethasone 2 cycles and ATG flu-bu based conditioning and cyclophosphamide on day 4, and just 5 patients had mild to moderate veno-occlusive disease managed with just supportive care. No diflunomide was used. 9 patients had grade 2 GVHD resolved with steroids. Only 1 patient had severe grade 4 GVHD. 5 patients developed limited chronic GVHD, 1 rejection, 1 death. Fantastic EFS and OS. So when this publication came, so we thought, why don't we also start doing a haplo with a technique like this? Somehow, I don't know why our experience was not similar what Suresh showed. We had a lot of issues. In terms of mucositis. Bad GVHDs. Their patient hardly had bad GVHDs. Our patients had GVHDs. Then we thought that, is it because of more mucositis that the patients are having GVHDs? Should we change the regimen? Then we spoke to somebody in UK, and then he said, don't use busulfan. Use a conditioning in which there is some thiotepa. So we used a modified John Hopkins protocol. John Hopkins, majority of the hematologists are aware of flu-cy, single fraction of TBI, PTCY, and we added thiotepa. We added thiotepa 10 mg per kg. So thiotepa, flu-cy, TBI, ATG, 4.5 mg per kg of rapid AG, hemoglobin, PTCY, and it just changed the outcomes. Very limited GVHD. Some mixed mechanisms were there and fantastic outcomes. So a similar publication came from the southern part of India from Dr. Revati Raj group. So they treated their patients with a similar protocol. So it was a retrospective study which included children with thalassemia who were transplanted between September 2017 and 19, and the patients were given 2 cycles of fludarabine, dexamethasone, but the conditioning was very much similar to what we were doing. ATG, rabbit ATG of 1.5 to 2 milligram per kg for 3 consecutive days. So they were using 4.5 to 6, we were using 4.5. Thiotepa 10, fludarabine, cyclophosphamide, single fraction of TBI, stem cell infusion, peripheral blood stem cell collection, day 3, day 4 cyclophosphamide, and then tacrolimus was the GVHD prophylaxis. So we were using tacrolimus with MMF. They used just single drug tacrolimus and very respectable outcomes. 75% EFS. Just 3 patients out of this cohort, I would say 4 patients had rejections and rest all were alive. 75% EFS thalassemia survival and OS of 100%. So we were also seeing, so now the GVHD issues went down. Patients were not having GVHD what they were having with flu-bu, but there were mixed chimerism issues. Quite a number of patients who were having mixed chimerism, stable mixed chimerism. There were some who were having mixed chimerism initially and were rejecting. So we thought, can we do something different? This is a reduced toxicity regimen. Can we give something different with which we don't have mucositis, which is a probable reason for GVHD, and we can achieve full donor chimerism? So then we started we made a change. Rather than having cyclophosphamide, we introduced triosulfan. So ATG, TTF, thiotepa, triosulfan, fludarabine with PTCY, less of GVHD, 100% chimerism. Whatever transplants I have done in last couple of years with this regimen, in last 2 years I've been using this regimen, 100% patients have been alive with 100% chimerism. So this is a learning curve. We started our haplo program for thalassemia. Quite a number of bumps initially with GVHDs, then mixed chimerism, and now a protocol is well set. Rabbit ATG, TTF, PTCY, a smooth sailing. Then aplastic. So there are two choices. When you think of doing a transplant for aplastic anemia, idiopathic aplastic anemia, either you can give a drug called ATG with cyclosporin, which works in around 60 to 70% patients, or you do a transplant. If you have a full match donor in the family, then there is a 90 to 95% chance of cure. So trust me friends, aplastic is really bad because these patients can get bad fungal infections, bacterial infections, they can die because of bleeding. So these patients, it is very important to send these patients to a correct center where transplant can be done. So 60 to 70% chance of curing them with ATG and cyclosporin, 90% chance with a match sibling donor. So should a person who doesn't have a full match donor in the family be given ATG, or you do a mud or a haplo transplant? And with this publication, that changed our practice of doing, I would say, treating aplastic. So when you don't have a full match donor in the family and you have a patient of aplastic anemia, rather than giving ATG, we do a haplo transplant with this regimen. ATG, rabbit ATG, 4.5 milligram per kg. So on the first day we give 0.5 milligram per kg. For next 2 days, 2 milligram per kg. Flu-Cy, TBI, very much like John Hopkins, but the only difference is that they gave TBI, they increased the TBI dose to 400 grays. Rather than 200 grays, they gave 400 grays because with 200 they were seeing more of rejections. For the relapse refractory patients, those who were previously treated, they were still continuing with 200 grays, but the treatment naive patients, 400 grays. Fantastic results, and I will just show you the outcomes. If you see the OS for relapse refractory, it was 100%, and for treatment naive, 86%. You see, if you don't have a full match donor and you're giving ATG, you can cure 60, 65, 70%. Whereas if you do a haplo transplant, you can achieve a EFS of close to 85, 90%. The problem with ATG, it's not a bad drug. People ask me, if we have a standardized protocol, if we know that if we don't have a full match, we give ATG, still we can save 60, 70%. Why to subject them to a haplo transplant? Friends, ATG takes its own sweet time. It's not I would say, transplant works very fast. You transplant a patient and on 14th day his hemoglobin TLC platelet increases. Whereas if you give ATG, it may take 3 to 6 months for your red cells, white cells and platelets to recover. That means for 3 to 6 months the patient would be immunocompromised, would be at risk of infection, would be requiring platelet transfusion. Cost, which is a very big problem in our country, cost would keep on building up. So with a haplo, this conditioning, if you achieve an outcome like 85-90%, why not do a haplo rather than subjecting these patients to ATG based therapy? Coming to Fanconi's transplant, I'll just briefly tell about my experience of doing a transplant of Fanconi's. So as money is a very big challenge in a country like ours where majority of people are still not insured, we cannot offer a T-cell option to each and every patient. So we started our haplo transplant for Fanconi's anemia almost 10 years back. I showed you the picture of the boy who was transplanted 10 years back, and that was the first successful transplant. That boy is alive. But the problem of doing a PTCY based transplant in Fanconies is the moment you give alkylating agent, cyclophosphamide, you see bad mucositis. People just fall apart. You see such a bad mucositis that you sometimes you regret whether I've done right or wrong. Whether should I have done the transplant? Because sometimes these patients they bleed from the upper gut, they have lower gut bleeding, bad mucositis, and when you have bad mucositis, that's a risk factor for having GVHD. So in the initial years, when we were doing transplants for Fanconi's anemia, we were having issues of mucositis, and we were having bad GVHDs also for these patients. So then we changed our protocol. So for Fanconi's, we no longer do a PTCY based transplant. We do a T cell depleted. We counsel the families upfront that with PTCY way, there is a high chance of complication. There's a higher risk of mortality. So if you can afford, then we can do your transplant at a center, and we are going to do a T cell depleted transplant. And with that, by God's grace, we have achieved a fantastic outcome. Though there is a publication from India, I'll just show you that from the southern part of India, which is still using that PTCY based technique, in which they have reduced the dose of cyclophosphamide. So this is the similar Hopkins regimen, in which they have reduced the dose of cyclophosphamide from 14.5 milligram for 2 consecutive days to 5 milligram 2 consecutive days. Fludarabine and TBI dose remains same, and they give a reduced dose of cyclophosphamide post transplant. They are also facing issues of mucositis, but still they were able to salvage almost, I would say, 70% patients. But with a T cell depleted technique, you can achieve a cure rates of 90%. That's what our experience is. I think we are running short of time, so let's move on to the last part of the presentation. Sickle is very close to our heart because quite a number of patients from Africa travel to our country, and we have done more than 100 transplants for sickle cell. And as there is no registry, there is no unrelated donor registry in Africa, it is very difficult to find a donor for somebody who doesn't have a full match in Africa. So the only practical option left for these kids is a haplotransplant if there is no full match in the family. And in our experience, a transplant for a sickle cell, you can achieve an outcome close to 90 to 95%, which you achieve in a full match donor transplant. So this publication came long back, and then in this they talked about the conditioning in which they use ATG, flu-cy, TBI, cyclophosphamide day 3, day 4, total 17 patients, 14 haplodonors, 3 match sibling donors, no TRMs, but engraftment was an issue. Just 62% patient engrafted, and then they added thiotepa. So after the initial issues of non-engraftment, they added thiotepa to their regimen, and the rejection rates went down. And similar protocol we've been using in our practice, and our protocol has got 4.5 milligram per kg of thymoglobin, 8 milligram per kg of thiotepa, flu-cy, TBI, PTCY, tacrolimus/cyclosporin, and MMF, and we achieve a cure rates of close to 90% in that. So these are some of the patients. We have taken the pictures with the consent of these families who have been transplanted at our center. Quite a number of sickle transplants, and sickle is something which is we are passionate about. And I'll just summarize. For thalassemia sickle, target is to have a reasonable good quality of life. MUD and Haplo HSCT are promising tools for unfortunate kids who don't have a match sibling donor. Experience is adding to the success story of these transplants. For aplastics, the target is to make sure that engraftment is there, and then there is no GVHD. Less chemo, more of immunosuppression is required. Haplotransplant may be a better alternative to ATG. For Fanconi's, again the target is to make sure engraftment is there is no GVHD. Bone marrow failure syndrome has better chance of cure than MDS and AML. So rather than these patients developing MDS or AML, it is better to transplant these patients early. Less chemo, more immunosuppression is required for inherited bone marrow failure syndrome transplants, and haplotransplant brings the future of hope to these patients. So with that, I would like to thank you all for a patient hearing, and I would be more than happy to take your questions after Dr. Bhargav's talk. Thank you.
That was an eye-opener to many of us, and great to hear from the expert in this field regarding the most advanced way of bone marrow transplant. Thank you, Speaker Dr. Vikas Dua and our moderator, Dr. Salim Al-Shamari. And we would like to felicitate Dr. Vikas Dua. I cordially invite our Vice President, Dr. Sajna Mohammed, to please come onto the stage and present our token of appreciation to Dr. Vikas Dua. Without wasting much time, let's move on to our second topic of the day, which will be haploidentical bone marrow transplant in leukemia. Let me invite our speaker, Dr. Rahul Bhargava, and to moderate this session, I am pleased to welcome Dr. Abdul Rashid Shah. Dr. Abdul Rashid Shah is a consultant in hematology and bone marrow transplant, Kuwait Cancer Control Center. He is trained in hematology, stem cell transplantation at MD Anderson Cancer Center, Houston, Texas. The University of Texas MD Anderson Cancer Center is the #1 cancer center in US at present. Dr. Abdul Rashid was also trained in bone marrow transplantation and cellular therapy from Moffitt Cancer Center, Florida, USA. We welcome you, sir, to moderate this session.
Good evening to all. I'm privileged today to have been asked to moderate this session. Dr. Vikas he gave the best possible outline of bone marrow transplant for those whosoever are medicos here, but non-transplanters. It was the best outline and possible that panoramic view. But before I introduce our second August speaker, I would just give a brief panoramic view of the bone marrow transplant, what it is for those who are non-hematologists or non-transplanters, because sometimes it gives a hitch once a person thinks of bone marrow transplant and he straightway goes to the toxicities. Oh no, this is not the thing. But since the inception of bone marrow transplant, which was done initially in Minnesota, which was done in a child for immunodeficiency syndrome almost 5.5 decades ago, since that time, there have been troughs and crusts in the transplant technology. It continued to be the only curative modality for many of the hematological cancerous conditions as well as benign conditions. And to date, despite of all novel treatments and therapeutic paradigm change, it continues. It's the only curative modality for certain entities. And most importantly, the issue used to be, as Dr. Vikas elaborated, it used to be the donor selection, because donor was the important thing. Not fully matched donors were considered to be giving the best possible results with less complications. But with the almost in last 1 decade, there has been a paradigm change in this area. And now haploidentical transplant is as good as matched-rated donor transplant. There has been an array of publications recently from EBMT, from China, and from others, where they prove haploidentical transplant is as good in terms of outcome as well as the relapse, cumulative incidence of relapse is less. And to my understanding, there's one more important thing. It has a more anti-GVL effect rather than compared to matched sibling donor. If you have MRD positive patient going to transplant, his outcome is better with haploidentical. And with the many technologies that Dr. Vikas mentioned, T-cell deplete or replete and are unmanipulated with modifications in the conditioning regimens and others, haploidentical is becoming now the thing of the day, because every person has almost 3 donors available, which was not the case. Now, for this topic, haploidentical transplant or unrelated transplant, we here have today Dr. Bhargava. Rahul Bhargava is Principal Director of Hematology and Bone Marrow Transplant and Fortis Group. He especially has interest in the haploidentical transplant. He has been trained for haploidentical transplant in Vancouver, Canada, and he'll be talking about haploidentical transplant in leukemias. Thank you, please.
Thank you. Thank you. Thank you, everybody. It has been invigorating for all of us to understand that fellow Kuwaitian hematologists are always there to save lives. Majority of people still think that I am a surgeon, and I don't know how many my fellow colleagues in Kuwait, they are still thought as surgeons. So I always have to tell them, no, we are not surgeons. We don't go in scrubs. We don't carry the knives. We just carry our mind on our hand and bring about changes in the lives of the people. So we don't cut anything, okay? So we just take 300 ml of blood from the donor, and that's it. And then utilize the body's immune system to kill the bad cells. And it's unfortunate. Anybody in this world can develop a blood cancer. I mean, let's be open to this and let's talk about it more commonly, that anybody in this sitting in this room can develop cancer at any moment of time. But what is the most common thing for all of us is that the science is always there to find the cure. When we started in 1960s, probably none of the cancer patients were surviving. And I still remember 8 years back, one of my patients at 40 years of age got a myeloma diagnosed at the age of 40. Because in India, there are a lot many people are younger. He got first transplant, survived for 3 years. They got a second transplant because he had 414. He got a second transplant, survived for another 2.5 years. And now finally he got a CAR T-cell trial done, like he's 1.5 years down the line. So you see the power of compounding. As your bank balance goes on and increasing in the compounding interest which you keeps on getting, similarly is the hematology. And that's the fun of being a hematologist. Never life is same on a single day. It keeps on changing from morning to evening, evening to morning, and similarly every day. And that's what keeps us going every day. Dear all, please, whenever your people are coming back to you, talking about blood cancers back home in India or here where they're asking your opinions, please be confident and proud of this fact that there are hematologists in Kuwait and in India who are striving hard to make this 0 to 70% and in probably a decade from 70 to 100%. That's the whole aim today as we survive. So the clock has moved from 0 to 70. I'm not saying we're not guaranteeing 100%, but the clock has moved from 0 to 70, and it's a matter of time that we will move on to 100. Because a lot of understanding of the body's complicated, intricate mechanism, how we deal with our body, has been unraveled. How the science has unraveled our body and how we function on a day-to-day basis. Why my mother, when I was in the womb, never rejected me. I mean, all of us were born from a mother, okay? They never rejected us, irrespective of their HLA, irrespective of their blood groups. What was happening? There was a placenta which was making sure that the immune system recognized the baby as their own, irrespective of the HLA. And my mother had 7 brother sisters long back. And I've got 1 brother. So we are in a shrinking world. And my son does not have got any brother sister. It has got only a daughter or a sister, what is called hematology. She kind of unfortunately donate blood to them. So she doesn't have any donor. So what do we do? And we all want to live longer, okay? We all want to see the beauties, how the Kuwait is going to be in 2030 and how India is going to be in 2040. We all want to see that. And that's why the half-match transplant was started. Not only early, because many of the people didn't have the donor. So if I have got a brother and sister, the percentage chance is only 30%. Real brother-sister, 30% chance. If I've got 4 brother-sisters, maximum goes to 40%. What about 60? So it's a chance that my brother and my sister, my brother or my brother, me and my brother has inherited the same HLA. But what about 60? We can't leave it for the chance. Then we understood that, okay, let's develop the registry. The way we match our clothes, the shirts and the trousers, similarly, let's do the HLA and keep a registry. So I take a cheek swab. Simple cheek swab, innocuous cheek swab, do the DNA analysis and put it on the net. And 5 years down the line, somebody will come to you that you can save my child's life. All you need to do is go to KCC and give 300 ml of blood, and the blood will fly to Lucknow or to US or to England. That 300 ml of blood will save somebody's life. Isn't that fantastic? And you have got 2 kidneys, 1 heart, 1 liver. Of course, you must be having a heart. I hope you have not given to your girlfriends and wives, but it's still with you. So if it is with you, then you have got only 1 heart. So if I take 2 out of 2 kidneys, I take 1 kidney, it is -1. But out of 4.5 million cells, if I take 300,000 cells, I'm sure you require a calculator to calculate how much are left. So please encourage yourself staying in Kuwait, and I request the KCC chief to encourage people to develop indigenous registries. The Kuwaiti registry, where people can get a match unrelated donor transplant done. The way he established the state-of-the-art transplant center, the mud will also go a long way. And those ethnicities who does not have the registry or representation in the registry, like Indians, 1.4 billion, very, very proud. The moment we say how many people are on the registry, we have got only 300,000. What are the rest doing? We are afraid of giving blood, so they will not give blood, okay? As a community, we will not encourage people giving blood. We are afraid, we will run away. Okay, we have all seen 20 years back when we left the country, how difficult it was to get a blood donation done for their own sisters, on their wives and their daughters, just a 300 ml of blood. I mean, still, the country has changed, but still that aspect has still not changed. It will take time. But rest of the things in terms of infrastructure, in terms of expertise, in terms of infection, everything has improved. And that's how the half-match transplant started coming in, because the need of a human being to live longer. Longer, don't ask the question longer, where? Henry Kissinger died at the age of 100 years. Okay? So if all of us continues to do what we are doing today, and the bounties of the science comes in, we are sure we are going to live 100 years, irrespective of cancer comes and goes. And that's what the whole beauty is. And this is where it is not, when we see the end result, we think that it has come overnight. No, dear. It has taken efforts of 2 decades to reach to where we are. And that's how this shows, starting from 1980 to 2020, how each and every aspect of immunology, how in every aspect that I cannot give blood to anybody in this world, except when my blood group is matched, has been unraveled. From the mice in 1950s to humans in 1960s, and repeated failures have paved the way to the success of what we see today. So we should be very, very grateful to our past, how people painstakingly have worked hard to make the future of what we are living in. And similarly, we all have to work hard across the nations to see that every single citizen of every single country has got a fair chance to live longer. And that's where the Indian healthcare actually comes in. And that's what we are going to talk about. Advancements in establishment of algorithm for best haploidentical donor. Should I take a female donor? I'm so sorry. Don't take me gender specific. We don't take female donors. We only take male donors. The simple fact to that is, once a multiparous female is there are a lot of antibodies within the female body. And that can lead to a lot of graft versus host disease, what Dr. Vikas has already told. Optimization of a conditioning regime, very, very important. What drugs do you choose? How the drug will interact with the racial and disparities and the genetic disparities between me, Bangladeshi, Middle East, and the Caucasian. What the data we see from Caucasian, we tend to implement in Indian setting, we fail. And that's a journey of almost a decade which has happened when we started doing transplant in 2013, half-match transplants, of understanding that the same protocol the Caucasian can tolerate, Indians cannot. So it's a journey in itself. How do you choose the drug which will kill the bad cell, but not the patient? So patient has to be alive to see the goodness of a transplant. Okay? Shift from T-cell depleted grafts to unmanipulated bone marrows or peripheral blood in the adult setting. So since Vikas came back in 8 years back, I became an adult hematologist, so I only do adult hematology above 18 years of age. I don't do less than 18 years of age. That's completely entirely a pediatric domain for us in India. And that's how the success story of 250 transplants each year is being written in our centers, because somebody does the same thing, what they know the best. Enhancement of hematopoietic recovery through endothelial-directed N-acetylcysteine interventions. Then we understood that body can have antibodies. How do we take care of the antibodies? Can there be a biomarker for GVHD that I can predict the GVHD? For any hematologist sitting in this, believe me, when you're eating your best food, we are looking in a WhatsApp how the shit of a patient looks. He says loose motions, and we start having loose motions. That's a hematologist's life, okay? So my mobile still have got photographs. Each and every time a patient passes a loose stool, we have to ask what is the color of the stool, how does the stool looks like, what is the consistency, how's the pain, and it's a nightmare for any hematologist. I can vouch for my hematology colleagues that in the middle of the night somebody says loose motions, you will jump off the bed and you'll start running. You'll say come, 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 come. And that's what the life of a hematologist is. So GVHD still remains the Achilles heel to be won over. And that's what newer drugs like abatacept is coming up, newer drugs like ATG which are coming up, which can manipulate the T cells and their reactivity. Then should we transplant a patient when there's a MRD positive or negative, and improving the immunological, enhancing the immunological recovery so the bacteria and the funguses and the viruses does not take over your body. What are we dealing with is the viral infection, which is innate in us. All of us are having a CME infection, but they don't raise in your body. They do not raise their heads in the body. Why? Because your T cells are intact. So what is the playing field now? Is the T cells. So microscopically, from red blood cells, white blood cells and platelets, white blood cells to B cells to T cells, and in that T cells also, you're talking about CD45 RA and RO cells. My God. So if you are finding it difficult to listen to it, we have to practice every day for next 20 years also. So that's how you keep on seeing the newer advances. Indications is very, very simple. We can all things. The genomics is very, very integral part. Why my nose is different than your nose resides on the genomics. So more reliance on the genomics of any country, irrespective of the economic status. The genomics is very, very important in AML. Every single patient should try to get a genomics done because in a normal karyotype, 40% people are upgraded for a transplant. So as a transplanter, my idea of in AML is we are finding out who does not require a transplant. I'm not trying to find out which requires a transplant, but I'm finding an indication of not doing a transplant, which is 20 to 30%. Rest 60 to 70% requires transplant, and if done in CR1, the success is 80%. If not done in CR1, the success is 40%. Complete response 1. CR means earlier the better, because body gets battered with every chemotherapy which you've given. And these are the things which we have to look for, and these are the genetically modified things where classification of AML is very important, and we are writing a manuscript. Is 821 in a genomic determined arena is good risk? We can discuss tomorrow about 821 c-KIT mutations and accompanying mutations which makes 821 technically a bad risk and not the good risk. So I'll be tempted to ask this question in a smaller forum, that how do you feel your 821s are doing? And that's the indications for transplant. Any carcinoma breast patient who develops an AML, they require a transplant. So one of our patients of multiple myeloma, 6 years down the line, develops a TP53 associated ALL. We gave Dono-VCR, he develops a subdural hematoma. We gave inotuzumab, went into CR, gave blinatumomab, did a transplant, now he's 100 day 20. So how medications do help us based on the genetic marker is very, very important. Is outcomes between haplotransplant and matched sibling transplant in acute myeloid leukemia and first complete remission same? The answer to that is yes. And the data, randomized data, these cannot be randomized data, they are CIBMTR retrospective data of 1,205 patients, 336 patients underwent PTCI and 869 matched sibling transplant. It was almost the same. Multivariate analysis, haplo were not different with regard to overall survival, leukemia-free survival, non-relapse mortality, and grade 2, 4 GVHD. It means those patients who didn't have the MSD, they can be very well salvaged by half-match transplant. Because we were afraid that we will die. So in India, I asked my fellow colleagues, is 60 better than 0? Is 0 better or 60 better? I'm sure 60 is better. So when we talk about half-match transplant and they say, sir, we have heard it is difficult. We have heard it is complicated. I say, it is better than 0. Anything better than 0 is, we should do it. And that's how the half-match transplant story has evolved. And these are the curves which you can see that they were almost equal, except this curve which shows there was more of a GVHD in a half-match transplant than a sibling transplant. MSD versus haplos, in patients with high-risk cytogenetics, no difference were found in leukemia survival, OS, and between the types of the donor. So whenever you do a sibling transplant versus half-match transplant, if there's no sibling transplant available, you should proceed for a half-match transplant. Then the question comes, is haplo better than mud? So now match sibling transplant, 30% people who have got match sibling transplant, they go a match sibling transplant based on the genetics. And the reason is that more genomics you do, more you know whom to transplant early, which helps in determining the donor as well as preparing the donor psychologically, nothing else, and then they can be transplanted. What about 60? Should a mud be mandatory? But in our population, 1.4 billion people, 300,000 people are only on the registry, so can't find a mud. By the time we find mud and we started preparing, the donor ran away, donor backed out. So it was a necessity for an Indian setting to do something, because these people, there was an economic growth which was happening. There was a willingness in the people to survive and live with cancer. It was sometimes forced by the patient to evolve. Otherwise, we were complacent. And in 2013, we were happy with doing match sibling transplant. It was forced by the patient family that unless you don't do it on me, I will die. So you see how the economic situations when improves in the country also brings about innovations. And we were forced to come out of the reluctancy to do a half-match transplant, and the patients luckily survived these 11 years post-transplant. So in match, unrelated or haplo, if there is a mud, will you do a haplo versus mud? If you get a match unrelated donor transplant, yes, you should do a match unrelated donor transplant vis-a-vis half-match transplant. In our experience, less of GVHD, whatever the data says equal, but match unrelated donor transplant is easier to handle. Out of our cohort of 20 patients which we have done this year, it is easier, 0 mortality. So it means match unrelated donor transplant is almost equivalent to match sibling transplant, and then comes the half-match transplant. So comparison to match related versus half versus match, the 2 years did not differ between match sibling 10 out of 10 mud or haplo, which was almost equal. Please refrain from doing 9 by 10 mismatch mud, because there's a lot of mortality associated with that. So what we have understood is, it is as simple as that: sibling transplant followed by match unrelated, and that's why the registry will come handy to you, and it will also reduce the cost from a haplo transplant perspective, and then comes the half-match transplant. What about the conditioning? If it is a frail patient, should I use a conditioning regime which is less ablative? So transplant works in 2 ways. One is like a pan worm, which the chemotherapy given kills all the bad cells. Second, it harnesses the immune difference between the recipient and the donor. Understand this. There's an immune discrepancy between you and me. Between me and Vikas, though both are males, both are brothers, but there's an immune discrepancy. If I can harness the immune discrepancy between the 2 recipient and the graft, I can still kill the bad cells. So I can tag the cells and then kill it. So one is ablation and one is immune recovery or immune mediated cell kill. So RIC is basically immune mediated cell kill, while the myeloablation also kills the bad cells, but also kills the patient also. So depending on the condition of the body of a patient, you have to decide between RIC and the myeloablation. So what we did, John Hopkins was simple, flu-cy TBI, fludarabine cyclophosphamide TBI, which was non-myeloablative. You give it, patient does not have much of a problem, but the problem there was of a relapse because we were not able to kill the cells. And the immunological differences were not sufficient enough to kill the bad cells. We give Bucy, flu-bu, it killed the patient before the immune system started working. What do? So, very simple. Myeloablative conditioning, outcomes were no difference. There was no evidence of difference in engraftment between the groups. And use of post-transplant cyclophosphamide was associated with reduced graft versus host disease, stage 2, stage 3, and overall survival, leukemia-free survival, and GVHD. Impact of the conditioning regime was not much. So, but it was in a Caucasian problem. In our setting and in your setting, please be aware how the patient looks like depending on that. And the second important parameter is whether the patient is MRD positive or negative. If your patient is MRD positive and you give a RIC, he will relapse. If the patient is MRD negative and then you do a RIC, there's a higher chances of survival. So where we started, flu-cy TBI, flu-bu 4. And believe me, flu-bu 4 with cyclophosphamide, now paper has published, more chances of hemorrhagic cystitis. So flu-bu 4 went out immediately after 4 patients, developed pathetic hemorrhagic cystitis. Then came flu-bu 2, which was well tolerated, but still the mucositis was much, the GVHD was much. Flu-mel did tolerate people well, and this was all with TBI, flu-bu 4 TBI, flu-bu 2 TBI, flu-mel TBI, and flu-trio TBI. Then came the magical thing, flu-cy TBI, thiotepa, and ATG. Fantastic results, 70-80% survival. But the problem was the cost was going up. So we are in a country where we also have to be cognizant of the cost. We cannot use anything. We cannot do the transplant in $400,000. We have to do it in $40,000, okay? So how do we use the science at best? How we are different, better conditioning, use of triosulfan, and letermovir was brought in. So our experience with flu-cy TBI, which is published in EBMT, 14 patient, median age was 13.5, myeloid malignancies, median engraftment 16 days, acute GVHD 42.8, majority was grade 2, but 1 year survival was 71.4%. So in a half-match setting, 71.4% people in a resource crunch country where people said, we could get 71. And this is not the stoppage. The idea is to stop at 100%. Not to stop here. What do we do then? We brought flu-trio TBI because triosulfan leads to less of mucositis, less of T-cell expression, less of GVHD. And 7 people have been recruited. 1 patient has relapsed because patient was taken up with a refractory disease and rest are doing fine at a median of 130 days. So once we do at 15, we will publish this. But at this present moment of time, flu-trio TBI seems to be the best conditioning regime in a cost resource country, maintaining the cost at $40,000 US. And this was the same almost between the two. Graft source, we have shunned away from bone marrow. Peripheral blood has become the routine source. We don't give it more than 6 million doses, and things becoming better. A word on donor-specific antibodies. Sometimes what happens in the donor, you have got antibodies. Recipient has developed and known that if this is the donor and the stem cells come in, I will kill because there's a preformed antibodies in the recipient itself against the donor. So I'm ready with my missile. The moment you come into my room, I will fire it. So technically, DSA was always a problem. When you take a female, multiparous female donor, when you don't have a father, and you have to take a multiparous female donor, there is a chance of DSA being positive. The simple regime was tacrolimus MMF starting 2 weeks, give IVIG. This was the standard. This was the past till 2021. Then we used daratumumab, which has got published in Indian Journal. At this present moment of time, 2 patients, single agent daratumumab for 4 weeks, and DSA has become nil. From 20,000 MFI to 0. So daratumumab seems to be working, and another collaborative studies from US, from MSKCC will highlight this in the next year is daratumumab because it eliminates the plasma cells which are producing those antibodies. So understanding of the philosophy, physiology of the body is very, very important here all. Does MRD in active disease matters? Yes, it does matter. The survival is inferior, but if you are pushed against the wall, you can still use a myeloablative regime in a selected patient and can still do a transplant. We can do haplotransplants in active disease as well, preferably not, but if you are pushed against the wall and nothing else is working, you can still take. And there's a publication from Germany as well as we have got 6 patients into that, talking about how in active disease you can still do a transplant, but those have evolved from MDS. So we need to understand if it is a FLT3 mediated AML, then the active disease is not going to get hold on. But if it is IDH2 mediated, then probably your transplant can work better. Role of ATG. So when I said GVHD, we were trying to conquer the frontier of ATG. Now people are surviving. When people are surviving, first people were dying within 100 days. Now people are surviving. There's a problem of GVHD, graft versus host disease. What do? ATG was brought in, anti-thymocyte globulin. So you see how the evolution is happening. So we are thinking of eliminating the T cells from the graft. So you have a graft, you have a cells, which is composed of B cells, monocytes, NK cells. You put in an ATG before that and kill the T cells. And what do you see? The cumulative incidence of grade 2 GVHD was 17% from 42%. But it also brought ATG, also brought in CMV. And that way the letomavir did work. So if you see, the acute GVHD 23 PT-Psi, other regime was 59, acute GVHD was 4, chronic GVHD was 9. And in these subsets, ATG has worked very well for these patients. So similarly, another thing which has propped up now is abatacept, CTCL4 inhibitor, which is almost the same. So the future of transplant is looking bright because the GVHD is getting controlled on a day-to-day basis with the newer medications. So to prevent relapse, what do? Why 80% people are surviving longer in AML? Because we have understood AZA, DLI, and venetoclax can be utilized as an agents for maintenance strategy. We are using AZA 35 milligram per meter square from day 60 onwards, people who do not develop GVHD, 50 milligram for 2 years, and believe me, this has really worked well. And as we have a genomic data for all our patients, we do tend to use a lot of decitabine and venetoclax for 17P, which is a holy grail where survival was less than 20%. That group has also reached to 60%. And the maintenance strategy at this present moment of time is looking good. So just to conclude, it's not a surgery. This is how you collect from the vein, like Amitabh Bachchan, who's a famous hero in India. You just have to collect it from here, so you don't have to do any surgery. And this is how you transfuse back inside the body. You don't have to cut the bones. One of the conference in the China, people thought that we have to break the bones and collect all the stem cells. I said, no, you don't have to break bones. No fighting, okay? Only blood transfusion. This is what it looks like. And it's such a proud moment that we did last year, celebrated our 1,200 plus bone marrow transplants, now hitting at almost 2,000 transplants. This has been possible without this team. All the lab hematology, so they are all under one roof. The manipulation of the graft which takes place, we have a great hematopathologist with all the things under one roof, along with our wonderful nurses. With their backbone, we cannot function. And of course, the wonderful team who serves the patient while we are on these trips to deliver and share the knowledge across what we have learned over these areas. So what was the take-home message? We have an active proliferated hematology in BMT units. All kinds of BMT is being done. Sickle cell and autoimmune disorders are now matured. One of the largest teams, only team to have an infectious disease specialist. Now become a very common thing in India to have an infectious disease so that the NDMs which we talk about are no longer affects our patients. And every single patient can now do a stem cell transplants and hopefully beat blood cancers. All we require is the positivity in physicians' mind and encouragement because you are family physicians. And believe me, any country, anywhere you go, your hematologists are the best resource for you to beat blood cancer. So let's be proud and give them a thunder applause for all the hematologists working throughout day and night to beat blood cancers. Thank you. And this is the reward what you get in the end. So you can all enjoy. Thank you.
Thank you for taking time to share your expertise and insight with us. We appreciate the effort you both put into making today's session so valuable. Looking forward for more inspiring sessions in future. If you have any questions on any of these topics, or you would like any further clarifications on, this is the time. Please feel free to raise your hand. I encourage you all take opportunity of this precious occasion. Please remember to state your name and designation.
Good question for the sickle cell anemia. Have you put an age limit for which patient? Any patient who might have a severe sickle cell anemia, you would not transplant?
So in our experience, I do pediatric patients only, so I do patients under 18. We have done for an 18-year-old boy, haplo. We want the patient to be having DSA negativity before we do a transplant. In a benign disorder, we don't do transplants if the patients are DSA positive. Thalassemia, if we give a desensitization protocol and still the patient is DSA positive, we prefer the transplant. We don't take this patient for transplant because there will be a high risk of rejection. I think Dr. Bhargava.
So we have done
Any value of MFI?
1,000. In our practice, 1,000.
Go ahead.
If the patient has got an MFI or less than 1,000, then I proceed ahead. If it's still more than 1,000 after the use of desensitization protocol, so in my practice, I've done 3 cycles of plasmapheresis, rituximab, IDF, still the patient is positive, then we don't do a transplant. Dr. Bhargava has these 2 patients with daratumumab. I don't have experience with that.
So we do up to 25 years of age. We have done 4 patients of sickle cell up to age of 25 years of age, and the response has been very good. Just to add to that, even if the MFI is say 3,000, we can always do a flow cross match whether those MFI is going to do a complement mediated cell cytotoxicity or not. So one is best is MFI negative. Second, if MFI is positive, you do a flow cross match or a bead complement directed cytotoxicity assays to see whether they are going to kill the cells or not.
C1.
Yes, C1. Because sometimes what happens is the MFI might be high, but they might not have an ability to kill the cells. And that's how you proceed ahead. But anything above 5,000, I mean any number which you throw us, but we will always do a complement mediated cytotoxic assays to check whether they are there or not. And if it is there, then it's no. Then we use daratumumab as we have done in our patients.
Before daratumumab, what sensitization, desensitization you used to, and how long?
So nothing. So to be honest, this is again a serendipity. You'll be happy to know we do quite a amount of charitable work in India. We do with the government of India. We established 6 bone marrow transplants across the geographies where we do free transplants. And in that, because the IVIG and the plasma exchange was not possible, that's why we took the benefit of using, because daratumumab was available at that time. So he was given nothing. So he was first time he was challenged with daratumumab, 1 cycle, 2 cycles, and we could just see the curves coming down for the MFIs. And we could able to do that. And after 4 it was like 0, and it was aplastic anemia, who was on the deathbed. And believe me, this patient, his only thing which took him to the life was his father's persistence. When we said you're going to die with the 25,000 MFI, you please go back home and let me at your place rather than in Delhi. He just persisted. He stayed there in a state-run hospital for 6 months before we could brought him down with blood transfusions and other things, could find a half-match transplant, did a half-match transplant, and believe me, next month he will be a year. So once you have the money, which the government of India right now is spending quite a lot, you are seeing these success stories more often than not. So transplant is miraculous. Sometimes it's just miraculous. Of course, we do go back with the bad memories as well of GVHD, but use of ATG has actually brought those bad memories to good memories, both in terms of quality and quantity.
How is artificial intelligence likely to add to your work?
Sir, it's huge, sir. So right from artificial intelligence, if we talk about digital pathology is making huge inroads, because if you understand the landscape of India, the clinicians have gone on top. But what about the pathologists? The next revolution of pathology services in India is yet to take place. We keep on still missing leukemias for months together because none of the pathologists did thought about that this looks like blast. They said atypical cells, and atypical cells could be atypical, okay? So, we have established a digital scanner in Gorakhpur, if you have heard of Gorakhpur in eastern UP. That helps in finding out every week we pick up 2 new leukemias from there because somebody in Delhi is sitting and reporting that. So AI along with the digital pathology is going to change the scenarios because then we can actually build the database of the people who have developed GVHD. So all the Vikas patient of 2 years, we are now putting up the data into the machine learning that who has developed GVHD according to the race, according to the age, according to the conditioning regime. Let's see what it turns out to be because what the human mind cannot compute right now, the trillions tons of data, I think AI can do that. And AI can actually come up with saying, okay, if you use this algorithm, there are chances of 40% people requiring GVHD, so you please be better be careful because you have a new agent. So I think AI has got a very powerful application in hematological circles to predict and tell us what next to be done.
It is always great to hear about your alma mater, Professor Shanui. You were there in 1986. I joined AIMS in 1984. And before coming to the talk,
I was 6 years at that time.
So my question is like Dr. Vikas. It is from my personal experience. One of my close friends' niece, she developed a post-viral aplastic anemia. Like lymphoma, leukemia, blood cancers, anybody develops, the whole family, friends will do anything for that person. We read in books how common it is, and I think the journey is similar, the costs are similar. This child survived because I could relate to the what you all are talking. We checked 20 relatives, 80 friends, and for the matching for bone marrow transplant, and ultimately the elder sister could donate, and the child survived. But when the girl missed her school for 1 year, she lost her hair and with all the side effects and all, but she's surviving happily, probably. I wanted to know simple post-viral, how common it is, and to Dr. Bhargav, how to register for this HLA? Yeah, in India or in Kuwait.
Yes.
Sir, aplastic anemia is a very common problem. So the most common reason of having aplastic anemia is still not known. It's idiopathic. So idiopathic aplastic anemia in which we don't know the cause. But the second most common reason of having aplastic anemia is a viral infection. Any virus on this earth can cause aplastic. We have seen patients developing dengue fever and then developing aplastic anemia. We have seen patients having cough, fever, viral processes going on for some weeks and then coming to our clinic with pancytopenia, do a marrow, and the marrow is empty. So viral infection is a very common cause to have an empty marrow. So that's the answer to your first question. And the second question is,
So one of the patients of Dr. Vikas, he transplanted 2 years back, now become a medical student. So I think it's a great journey. It's a journey to be seen and experienced. And believe me, there's a lot of positivity. We will still hear people dying, okay? It's not that we are perfect. Nobody's saying we are perfect. But from the forum and from the podium, what I'm saying is, the clock has moved from 0 to 60. Let's not remember those unfortunate 40 where the science is still imperfect. We are trying to make better every day through collaborations and through discussions and the communications like this across the countries. But 60% has got a fair chance to live, 60-70% people. And that's what we are proud of the facts. But for the simple reason, if you want to become a donor, Sir will one day will organize a camp for you and you can just have to give your cheek swab, and Indian Doctor Forum can all become a part of the stem cell donation process up to 60 years of age, where your stem cell will be healthy to save somebody's life. Believe me, race and ethnicity does play a lot of role. I mean, if we all willingly in the name of the God just comes forward and say, let's donate and let's be a part of this saving lives, I think a lot many people will survive.
So if you don't have a registry here right now, you can Google and you can go to Datri's website and you can become a donor.
Do we have a registry? We started it as an academic project. We had the 500 donors. That was, we wanted to do some sort of gene profiling and see what's the frequency of certain haplotypes. So we managed to do it, but it's didn't develop into public health issue. But hopefully in the near future.
So if you have a registry here in Kuwait, that's going to help the other people who are in the Middle East, because you are able to people chances of matching with them.
I'm Dr. Ali and I'm oncologist at ACC, and thank you so much for being part of the Marrow. Nice listening to you from India, doing such a good work. The only question to you is that you said you see patients across the globe basically. So do you change your conditional regime as per the ethnicity? How it goes?
For me, it's an answer. I would say if people coming from Bangladesh, I would definitely reduce my myeloablative regimes because of a poor health nutrition. We do tend to reduce that. People coming from state of Bihar, sometimes we do reduce our conditioning regimes from full myeloablation to say a rate conditioning and try to use more of a GBL effect to cure the disease. But yes, it has become very, very common for us because of the ethnicities. There are certain ethnicities where there is a high risk for GVHD. Even from a sibling match, they are higher risk. And that's from these centers where people come from. And second most important thing is, say, ALL. We were giving site TBI 12 grade. And the people like these two regions and another few couple of more, the whole cut was coming out. And the nutrition was so bad that they were not able to eat anything and the GVHD rates were high. Then we introduced ATG. But at the same time, we brought from 12 grade to 8 grade. So now, it's very simple. So you see how an experience from various ethnicities and doing a lot of transplants from across the world helps you to know how the people will become and how people are going to tolerate.
Sorry, now in India you're obviously doing lots of transplants, many centers. Do we have a registry by which you can have the data stored and analyzed later on?
Yes.
So that because anecdotal cases don't usually
Yes.
have so much, and a registry data coming from different regions, and you can really look at larger number of patients, then your experience which you have excellent results would be more.
Absolutely. So there's an ISBMT which is at CMC Vellore. Every year in March, we have to submit our data across the centers, and that keeps on analyzing. So Vikas has published quite a number of papers from Fanconi anemia, large 180-200 patient database talking about how the Indian setting has improved upon. So it's a very well taken point, and everybody contributes to that registry. And that's how the EPMT data, which I didn't show today about our own center and what we have collected of 200 plus patients on EPMT from Kochi. They have collected last time in ASH, and that's the data is still there. So I think a lot of, and there's another registry-based system which is like HCC, Hematology Cancer Consortium, run by Vikram Matthews, where we contribute our data to. So one is individual center data, another is how the Indian data from the registry-based data, how we can look at it. But sir, still the biggest problem with the registry-based data is what we are not able to understand, and what we are not able to capture is how many times a patient requires the admission post-transplant. What is the frequency of CMV reactivation if you use a certain conditioning regime? So what we are able to capture is you do flu-bu versus flu-trio. Flu-trio is superior. But where is the health economics of a flu-trio is saying there are less number of admissions. How many times a GVHD will happen? So those registry-based data, and from a US counterpart also, certain economic aspects of the data has not been able to capture, which we have to do it on our center, because people across the world travels to get a transplant done. Because you cannot send a patient back with the 30 times loose motions back to their country and say, you go and somebody else will take care of you.
understand that, but it all depends on what kind of data one is capturing.
Same CIBMTR.
What protocols we are using. Are there, because registries usually will lead to standardization
Yes.
of protocols across locations and therefore improve results.
Absolutely. So CIBMTR. So our data is in accordance with the CIBMTR pro forma. All our discharge summaries are according to the CIBMTR 10 pages pro forma, where you have to fill up everything. But beyond that also, we are also trying to capture into a health economic model of ours what best to utilize. And that's how this Fluke Trio ATG, Fluke Trio versus Fluke Duo, Fluke Trio seems to be, it is p-value superior in a large registry database. But use of ATG is because our center is using, and now we are going to publish it and put it together. Let's see.
Dr. Mohan.
Yeah, thank you, Dr. Rahul and Dr. Vikas, for nice lecture. I have one question regarding the GVHD, chronic GVHD especially. Okay, usually skin GVHD, liver GVHD, or GIT, and lung GVHD. Lung GVHD is actually very disaster condition if it is settled, if it is happened. In your experience, is there any other predictor by which we can detect lung GVHD early? This is one. Second thing, your hospital is in center of India, and some people coming from 4,000 kilometers to your center. How you are monitoring for that patient?
So the second question is very simple, sir. Every single patient of ours has got a WhatsApp group with us.
Okay.
So every single patient whom we do a transplant has got a WhatsApp group with all my department, and every first 90 days, every 4 hourly, they send everything. So if they vomit, they'll send the photographs. If they have a loose motion, they'll send the photographs. And later down the line, there's a set protocol of 3 months what they have to do and send it across. So lung GVHD predictors for the lung GVHD is basically in our setting is only the acute GVHD and the pre-existing smokers or people who have got interstitial lung disease. Other than that, we have not been able to find into a larger database what are the predictors who will develop the bad whoop and will get into the crippling where they will almost require a lung transplant. What has worked for us, of course, in a non-malignant setting, the azithromycin protocol along with fluticasone has worked in. The latest paper which has come up that azithromycin, if you give for too long, it suppresses the T cells and the chances of relapses starts. The chances comes up. We have stopped using azithromycin, but at the same time, what has worked is imatinib and ECP. So ECP is the one which has worked for us, and that too twice a week till 6 weeks, and then once a week, and then once a month. The ECP tends to work best for a lung GVHD, but other than that, you talk about Jakavi, you talk about ibrutinib, you talk about anything, it doesn't work.
In our experience in pediatric age groups, so if you have a patient who's got chronic GVHD, then we do a baseline PFT. A patient more than 6 years of age, we do a baseline PFT, and we call these patients at a 3-monthly basis, and we repeat the PFT. Because if you go by the NIH scoring system, a score of 2 in NIH score takes you to severe chronic GVHD. So lung GVHD is bad, and what Dr. Bhargav is saying that in our practice, if somebody is not responding to pharmacotherapy, steroids plus minus cyclosporin, then we try to take these patients for ECP therapy. Somehow, in pediatric population, as you know that FDA has approved Jakavi for patients who are more than 12 years of age for chronic who have got chronic GVHD. Those who cannot afford ECP, then we put these patients on Jakavi, and we have seen good responses. Yes. So in our institutional policy, we do it 3 monthly if the patient can come for a year, then every 6 months, and if there is no further deterioration, then we stop it.
You have incorporated any biochemical markers for prediction of GVHD, which are
don't have
investigational?
We couldn't find and we could not get the kit which the US is saying there is, but we could not get the kit. So, and we are not able to develop an indigenous marker for that.
You are doing most of the benign, and what's your goal of donor cameras in benign settings? Because it necessarily has not to be 100%.
Absolutely, sir. It depends for which condition you're doing a transplant. If you are having a mixed chimerism and that to a stable mixed chimerism, then we are happy. As long as my myeloids, my T cells are more than 25%, it's not dropping below that, and it's not dropping, it's a stable chimerism, we are happy.
About 75% usually, or 75 to 90?
Sir, I would say that it should not be dropping. If you have at least a 25% chimerism, but we do split chimerisms in India, if you have at least a 25% T cell, 25% myeloid chimerism, and let's say I have a patient of thalassemia. I have a patient of thalassemia whose T cell chimerism is 30% and myeloid is 26%. He's maintaining hemoglobin of 8 of between 10 to 11 because the donor was thalassemia minor, so we're not worried, and it's been more than a year. So stable mixed chimerisms in benign disorders, we're not worried.
Do you intervene between, for example, 75 to 25? Do you intervene like DLI? Because this is the situation where it was.
So the problem in benign disorders is that you don't want a GVHD to happen. You give DLI, there are chances of GVHD happening. As long as the patient, though the chimerism is going down, let's say it goes down to 20%, still is not requiring transfusions, his hemoglobin is not dropping, then you don't intervene.
Another interesting thing, one of our colleagues, Dr. Pallavi, she did on 5 patients when there was a drop in chimerism, she increased the dose of MMF. So the conventional thing was to remove the cyclosporin, but instead of removing the cyclosporin, she increased the dose of cyclosporin as well as added an MMF. And she was able to achieve a full chimerism in this 5 patients. So this is an interesting paper which has got published. It's talking about increasing the dose in a stable mixed chimerism to make it 100%.
It is a well-known fact that in aplastics, if you have a patient who has got an aplastic anemia in which you are using a reduced intensity conditioning and the chimerism is dropping, then rather than taking off the immunosuppression, you increase the immunosuppression. And that's what we do in our practice also.
Dr. Syed?
Hello, sir. Good evening. I am a clinician in hospital. I am listening to all the hematologists. God bless you, both of you and all the moderators for doing a great job. I am working for Vani Hospital. I just have some points I want to ask you. I have 2 questions. One is the incidence of infections, viral infections post this bone marrow transplantation. And second question is, how are you expanding it to other diseases? And is there any age restriction and you go ahead? For example, some people are, people who have muscular dystrophy or some sort of this thing, they are looking for India to go there and get these things done.
I'll answer the first part of the question.
So this is a field which we as clinicians we see them, so that I wanted to ask you.
Right,
Thank you.
Answering your first question, when you do a transplant, when you give chemotherapy, when it's a myeloablative chemotherapy, when neutrophils goes down, there are more chances of bacterial and fungal infections. Once your neutrophils start coming up, once the engraftment happens, then chances of viral infection goes up. Viral infection means viral reactivations. We all are infected with CMV. If you look at 99% population of India, they are CMV positive. That means if you do IgG levels of CMV, they are positive. So there is a very high chance of reactivation, especially when you do alternate donor transplants. More the mismatch, more there are chances of complications. So in our experience, CMV is a thing which we need to watch for, and we do weekly CMV checks. We do every week, we do CMV PCRs every week after the transplant in a case of matched sibling donor transplant, whereas if you do a alternate donor transplant, we have to look for 3 viruses, which is adenovirus, EBV virus and the CMV virus, because these viruses can reactivate and you need to act. Even at the asymptomatic stage, you have to start them on preemptive therapy so that they don't damage the organs.
The second answer to the second question is very simple. Any degenerative disorder has got no role to be treated with a transplant. Only place where you can intervene is an autoimmune disorder, and that's the budding stage where you should, and are improving outcomes being seen. Some say systemic sclerosis, multiple sclerosis, refractory SLE, Crohn's disease. So Bharin has got a lot of Crohn's disease for some unknown reason. In India, we don't see too much of a Crohn's, but we see more of ulcerative colitis. And last time when we were in Bahrain has got a lot of, at younger age also, majority of people are having Crohn's disease versus ulcerative colitis. So Crohn's disease is autoimmune. So anything which is autoimmune mediated, we need to do a transplant, and that can be salvaged by a simple protocol of cyclophosphamide and ATG. Cyclophosphamide and ATG, which ablates your T cells and train your T cells not to become terrorist again. It's as simple as that. But in multiple sclerosis, there's a very thin line between an autoimmune feature from autoimmune to degenerative disorder. So if you have a RRMS or a primary progressive, that's an autoimmune in nature. The moment it crosses the line to secondary progressive, that's a degenerative in nature, where the transplant will not work. So it's very, very important to see whether the MRI is being lit up or not. There is no role of stem cells for cerebral palsy. There is no role for muscle dystrophies. There is no role for ALS. Any atrophy, degenerative disorders, bone marrow transplant does not work.
Actually, doctor, regarding the Northwestern University, they have been doing a lot.
Yes.
On the clinical trial, but
Yes.
they never published it.
Richard Bird.
Yeah.
Richard Bird.
Richard Bird.
So now, if you see, sir, in past 4 years, there are at least 40 to 45 publications from various groups, from a stop trial to a JAMA whole, JAMA neurology dedicating 5 articles on role of bone marrow transplant in today's era. And that's how the science, even American Society of Hematology has issued a position paper in terms of saying in 2021, those people who are 2 lines refractory can be subjected for an autologous transplant. But the biggest thing is the choice and selection of the patient at the right time. If you have a crippled person who cannot move or cannot see from the eyes, do not expect a miracle. That eyes will going to come back. Because when people travel so far, they think if I have lost my eyesight, it's going to come back. No, it should not happen that you lose an eyesight or you get crippled, because MS is worse than a leukemia. In leukemia, either you live or you die. But in MS, you suffer. In MS, you become crippled. And at the peak of your height of your life, when you are doing the maximum in your life. So it's worse than a leukemia. So we need to be aware of these facts, and we can always talk about in a larger forum, the neurologist, when and how, and we can discuss the literature behind it and the science behind it, that how the ATG makes your cells, T cells, dysfunctional for at least 16 months.
We are running short of time. We'll have the last question of the day.
I'm Dr. Surana, working in Promani Hospital. My query is not scientific, but it is economical point of view. How the patient, those who cannot afford, and how you are trying to treat, and how is the coverage covered. And the second thing is, the people who can afford, and if there are there any specific health insurance schemes which include this type of conditions, or it covers under general insurance?
So from an Indian perspective, I can very well tell you, sir. Now it has been started getting converted into the healthcare system and healthcare finances as well as the insurance. Okay. So Star Health, Apollo, HDFC Ergo, all these gives you a good cover for bone marrow transplant as well. The first part of your question was more easier for me, because we are in the process of establishing bone marrow transplant with the government, within the government institutes. So if you have heard of a place called Indore in Madhya Pradesh, so there's a 10-bedded bone marrow transplant unit, 5 being run by our American colleague Prakash Satwani, and 5 is being run by us on the adult side, where the money is given by the government, and all the people who cannot afford the private healthcare goes for a transplant there, and the success rate is close to 90%. So we are very choosy in picking up the centers. Okay. Then there's an ESI, Employee Security Insurance, which covers almost say 2 crore people. Okay. And they get free transplant in that. 40 bone marrow transplants have been done. So that's in Faridabad. So if you talk about Bikaner, there's another place in western Rajasthan. Bikaner, we established a bone marrow transplant where they get free of cost. So as we are speaking, our mobiles, both of our mobiles never stops. They're like 24/7. The only time our mobiles get stopped either in the flight or it gets run off the battery. Because every single center is connected on a digitally through a WhatsApp. And that's an amazing say that you can actually start doing transplants remote side.
But with your Patient has to come to you for all the details, investigations?
No, so they just have to go there to this center. There's a doctor, there's a nurses who are trained for bone marrow transplant. They evaluate everything, do a video call, send the reports to us, send it across to us. And now we have a BMT plus data. So as we were talking about the registry, now we have a software which is, it's fantastic software. On a day-to-day basis, you keep on putting everything, and it actually can do the computing for you and help in publishing the paper. One of the reasons why we never published, India never published paper to show their strengths, irrespective and doing of so much of work, was twofold. One, they were implementing the knowledge what they are getting from the US. So our majority of time went into implementation of the knowledge, not the innovation of the knowledge. Now this is the India which is now hungry for the innovation, because when I started in 2006, there were like 80 hematologists across a population of 1.3 billion. The population increased. Similarly, the hematologists from 80, it has become 350. So each passing year, people will pick up the disease, and you see in the next decade what will happen is, I am talking about AML. If you have an opportunity to listen to me again, then I will be saying I only do myeloma and lymphoma, or myeloma and AML. I don't do anything else. And Vikas will say, oh, I only do sickle cell and thalassemia. There was a need in the country when we became hematologists to do everything, because we could not afford to be choosy. Now it's a time with the economy growing. We are 3.7 trillion economy, and 2027 might be a 5 trillion economy. There's a hunger in the people to live longer. And if somebody asks, what is the age? 70. If you are fit, you are doing jogging at the age of 50, I'm sure at age of 70 you will be fit. Will not be have a punch like me, and diabetic and hypertensive, and your heart is not working, and then you don't do a transplant. So you see a lot of India changing in next decade, because the healthcare has become the priority for the youngsters. We never talked about work-home balance. Did we ever talk about it? I never talked about that. I worked like 18 hours a day. Now today's country talk about, is there a balance between the home and the house? I mean home and the office. There are people to start talking about it. So this is an India which is growing in nature, changing its strides, and that's the whole evolution. What happened in America in 1900 is probably happening now with much faster pace, and with a profound knowledge that yes, we have got a lot of things to achieve. And that's the strength and the beauty, is that we are not only seeing the capitalistic world, but we also understand the social values that every single person, irrespective of their socio-economic condition, needs to be treated. And that's the democratization of the BMT which has happened in the past couple of years. And that's what we bring it on the podium today itself, is that we are no less than any of our counterparts in the West at this present moment of time. It's just the perception in the mind of the world has to change, that India has moved on to become the supporter of a democratic healthcare which is affordable to all.
Thank you, doctors. Thank you.
Do you by any chance want to move away from BMT to that's becoming the health minister? My vote. Just now I told him same. Just now I told him that you have any political affiliation.
Thank you. Thank you. I'm sure we all have more questions. We can interact during the dinner session. To make this session more memorable, we are going to felicitate Dr. Rahul Bhargava. I cordially invite the General Secretary of Indian Doctors Forum, Dr. Thomas Koshi, to come onto the stage and please present the memento. Thank you, doctors. A thankful heart is not only the greatest virtue, but the parent of all the other virtues. I invite Dr. Ashok Deb for the vote of thanks.
Good evening, everyone. It was indeed a unique and special category event. It has been our great honor to be a part of this prestigious event. We have been in a different world for quite a while. On behalf of Indian Doctors Forum Kuwait, I would like to convey my heartfelt gratitude to our Chief Guest, His Excellency, Ambassador of India in Kuwait, Dr. Adarsh Shaikha, our special guest of honor, Dr. Ibrahim Al-Tawala, President of Kuwait Medical Association, Dr. Salim Al-Shimari, our special guest of honor, Consultant and Head of the Department of BMT at Kuwait Cancer Control Center, I want to thank sincerely the Ministry of Health, Ministry of Interior, and Kuwait Institute of Medical Specialization. We are indebted to the doctors from the Fortis Healthcare of India, Dr. Rahul Bhargava, and Principal Director and Chief of the Hematology, Hemato-Oncology and BMT, Dr. Vikas Dua, Principal Director and HOD of Pediatric Hematology, Hemato-Oncology and BMT, and their associates, Mr. Shubham Dhankar and Mr. Shubham Talwar, for perfectly executing all the logistics for bringing the speakers here in Kuwait. I would like to thank the management of World of Astoria and the staff. And I also like to thank Indians in Kuwait, the organization Indians in Kuwait, IIK. Please give a wide round of applause to the guests and the speakers, to all the doctors who have come here today to make the event a memorable one. Thank you once again, and thank you all.
I hope both the sessions were very effective and fruitful to all of us. I'm sure you all have imbibed new learnings from this. Now, the dinner is ready for all of us. I invite all of you to please join us for the dinner outside. Thank you. Thank you so much.